Good afternoon, everybody. Thank you for joining us this afternoon for this Leukemia Care webinar. The objective of the webinar being to discuss how can we get the best out of remote consultations. That's in the majority telephone, but in some cases audio. I think we all know that there are many challenges and potential barriers to just using remote and telephone only. We'll start off with some broad discussion over these challenges, and the panel will contribute to that. So please do ask questions if you've got anything you'd like to share. Just to give you a little bit of housekeeping, unfortunately, you're not going to be able to ask questions directly. If you could post your questions into chat, these will be picked up and we will answer those during the discussion. That's if you're in Zoom. If you're on Facebook, as this session is being streamed live to Facebook, please pop any comments that you might have, questions into the comments box, and my colleague will pick those up and forward them to us here in the panel. I hope everybody's comfortable. Let me introduce myself. My name's Nick York. I am a patient myself, and we have two patient panelists with us. And I am the Patient Advocacy Healthcare Liaison Officer for Leukemia Care. This session will be videoed, so any of the information that might be shared during the session and slides will be available on the website afterwards, and you can then revisit at your leisure. So may I take the opportunity then to introduce you to our terrific panel. Perhaps we could start first with our patients. Maybe Steve, you could introduce yourself and your connection to the topic and what you do in the arena.
All right, good afternoon, everybody. Yes, my name's Stephen Davies. I'm 1 month short of 18 years of having CML. It was a very different thing 18 years ago to what it is now. I run the CML patient care group at the London Hammersmith Hospital. I'm also chair of our local GP surgeries patient participation group. And as from tomorrow, I'm going to be one of the Cancer Insight panel for Pfizer pharmaceuticals. So I'm quite involved in the arena. By profession, I'm a driving instructor, so nothing to do with any of this. And I'm also a leukemia care buddy. And as you can see, I've got a leukemia care t-shirt on, and these symbols here are 9 and 22 chromosomes, which is makeup of CML. So that's me. Thank you.
Thank you, Steve. You bring a wealth of experience and perspectives with you, and a long-term user of remote consultations as a CML patient. So looking forward to your inputs and the discussion we're about to have. John, can we introduce you? Would you introduce yourself? You're muted, John. John, can you hear me? You're muted.
Thanks, Nick. Hello, my name is John Perkins. I've got CLL. I was diagnosed in 2015. I had FCR chemotherapy in 2018 and achieved full remission very rapidly. I'm now in my 4th year since that and remain in remission as my blood tests today inform me, which was good. In my past life, I'm a retired GP. I say that my medical career is now entering its 42nd year, 35 as a doctor, and I'm getting into my 7th year as a patient. So I've seen this situation from both sides and realize how important it is and what challenge it can be.
Thank you, John. Great news on your testing status. Great to hear you're still in remission. And yeah, really looking forward to your joint perspectives from two hats, as you're now living this from a different perspective. So thanks for joining us. Maybe perhaps we could go over to our healthcare professionals and over to maybe yourself, Leanne. Would you like to introduce yourself?
Hi everyone, my name is Leanne Palmer and I'm a CLL clinical nurse specialist based in Oxford. I work at the Churchill Hospital. We've got a cancer centre there, so I'm here to give my advice from a healthcare professional side of things.
Thank you, Leanne. And Phyllis, last but not least.
Hi, thank you for inviting me. I'm Phyllis Patterson. I am I wear many hats actually. I am a chronic myeloid leukemia and myeloproliferative disorder, bone marrow failure, which includes aplastic anemia and PNH. I'm a clinical nurse specialist and I work at Adam Brooks Hospital in Cambridge. And obviously since the pandemic, we've had to change all of our plans for reviewing patients over to telephone video. So with all of those challenges.
Well, thank you and welcome everybody. I'm really looking forward to our conversation. I'm just wondering, as you just pointed out there, everybody's become a little bit more familiar with having to have their consultations or their monitoring chats with the healthcare teams via telephone, or if not, in the rare occasions by video. It's probably, as I touched on earlier, maybe it'd be a good idea, maybe just to sort of set some initial discussion going. To maybe discuss some of the challenges. So if we were to look at this webinar from a point of view, let's look at some of the challenges and potential barriers and how we can look how to overcome those and how the best ways to overcome those for both the healthcare professional and for us as patients to get the best from our appointments. So from that point of view, I'd probably maybe be interesting to ask our patients first. Yeah, what are your thoughts? I mean, there are obvious pros, benefits to telephone conversations rather than in-person visits sometimes during COVID, and there are negatives. So I'm not necessarily just looking for us to pluck out the negatives in the beginning, but we do have to, there are challenges that we experience as patients, and there are challenges that you experience as HCPs as well, Phyllis and Leanne. So I don't know, Steve, you're probably our longer served patient in the remote consultation community, and I noticed on the panel as well as that we're all living with chronic conditions, so this can be, you know, we're monitoring in the community during stable stages of our management is most likely. So I've prattled on long enough. Maybe we could just have a little session of sharing our thoughts around challenges that we have to try to overcome. Steve, any thoughts?
Okay, well, challenges. Having to go to hospital on a regular basis. For me, over the last 18 years, it's been every 8 weeks or so. I'm intolerant of the drugs, so my bloods need to be monitored more closely. One of the good things about a video or telephone conversation is that you don't have to go to the hospital. You can have your bloods done a couple of weeks before and have all the information, or the doctor will have all the information back, so that when you do have your conversation, you get the answers there and then. I quite like to go to the hospital and see the doctor face to face. Obviously, the last 2 years has been particularly difficult, and actually I've never had a video call to my consultant. I know her very well, but I'm one of those who likes to see somebody face to face, but having a phone call is great for me as well. I can plan my day better. Usually 3/4 of a day is written off if I go to the hospital. Whereas, you know, if I'm expecting the doctor to call me, say between 11 and 12 or 10 and 11, then I'm able to make myself available. Then obviously they run a little late, sometimes a bit early. So there's plus and minuses, but as I say, I prefer to see somebody face to face. Obviously, if you're in a stable condition, that's less necessary. So if your bloods are stable and your results are continuing, you know, in a nice orderly manner, then it's not that necessary to go. But if your bloods are going up and down, obviously there's a reason, and I think it's easier to discuss face to face than over a phone. I can see what the person is looking, you know, look into their eyes and see if they're trying to bluff me or they're holding something back, which is never the case at Hammersmith, let me tell you. But there's plus and minuses for both.
Thank you, Stephen. That's for sharing that, and maybe we can come on in a little while to discussing preference for face-to-face, and it's quite understandable. And I can see you've already picked up on, you know, anxiousness this can cause if your disease isn't stable or you want some information. And more importantly, what you just pointed out was a key thing: visual cues. And I think that comes from both sides. John, I'm going to ask you next. You've probably got some interesting perspectives because you've been looking at it from two sides of the fence, 35 years from one side and now for 7 years from this side. Please share your thoughts.
Well, I personally would prefer face-to-face, and as a doctor, as a GP, I would always look where that's possible to arrange to get a patient in. I'm aware when communicating between doctor and patient, it's a very important relationship, as we all know. The spoken word as part of the communication package is only about 7 or 10% of the message that we share with each other. Non-verbal and how the tone of our voice and how we actually talk to each other, as Steve has just alluded to, is actually incredibly important. So I think it's important to remember that it's hard for us, but it's also hard for the doctors. I mean, Leanne and Phyllis can contribute their bit in a minute, but I think it must be very difficult for them, particularly if we as patients are giving messages that we're trying to hide something or anxious or not understanding or not paying attention. So it's a complicated one, and I think that I would see it as developing a partnership. If you know the person doctor who's ringing you, of course, it's much easier because you can hook into previous experiences. In fact, tomorrow I have my first telephone consultation with a doctor in 6.5 years. So I've always had the same doctor. I've been very lucky. Tomorrow I'm actually facing a doctor I've never heard of. I don't know why she's ringing me, but I'm being assigned to somebody new. So there's a little bit of trepidation, even as knowing my way through this. Will they have read my notes? How much will they know about me? How much time, precious time, do I have to spend, updating them? And it must be very difficult on your side if you're, from their side, dealing with patients with considerable complexity. As Steve was saying, my blood has been stable. I can largely manage myself. But if you have complex hematological problems, which are fluid, and comorbidities, and trying to find your way through on a telephone, that's very challenging. And it's challenging for us as the patients and also for our medical advisors. So this sort of video, this sort of thinking about what we can do as patients is really important. I have my own checklist and I have my own way of doing things, but perhaps I can go on to that presently and hear from Leanne and Phyllis what they feel we could do to support them.
Thanks, John. And you've struck a keynote there as patients and as doctors. Is one of the potential barriers is building that all-important relationship, and the phone or remote consultation is not happening. And it's especially hard, as you just pointed out, if you've never spoken to the person before, you don't know them and you can't see them and you can't initiate the beginnings of that relationship. So that's really helpful. I'm just wondering, I think we'll come on to discussion about what can help and what can patients do to help. And we'll also look at what healthcare professionals can do and do aim to do to help. Maybe I could throw it over to our clinical nurse specialists. I think you guys from what I see from my side of the table as healthcare liaison officer, talking with everybody, seem to have been handed a lot of the work of remote consultations and telephone clinics, and especially in COVID. Maybe Leanne.
Yeah, so actually in Oxford before COVID, I was actually running nurse-led telephone clinics. So it wasn't completely new, this concept. What was completely new is those patients that would have already previously been on telephone clinics, I would have already struck up a relationship with, and we would have already known each other quite well. And I think that's the bit that we found challenging. Like, one of my concerns from a healthcare professional is, if I've not met them, a patient, will they feel as comfortable to just pick up the phone and call me? Whereas if I've actually met you face to face and I've said, you know, ring anytime, and you've met that person, and you're not just a name on the card. And that's kind of something that we've been working on a little bit in Oxford. So we've put together like a leaflet with the key core members of our team on, just to maybe help just a little bit with that continuity. So there's at least there's a face of when you're speaking to somebody on the phone. When you first mentioned this question, Nick, one of the things that I wrote down was communication. It's something that both Stephen and John have both mentioned, I think, from both angles. And I think it goes both ways, that you as patients can't see our communication side of things, but actually we get a lot from a patient's communication as well. And how people are managing at home, like how emotionally you might be coping, and, you know, whether that, you know, triggers extra questions for us to be asking. We do try and ask on the phones, particularly, you know, because we've been living in difficult times with the pandemic, how people are coping, and hopefully, you know, the teams are having it where, you know, they are approachable, and, you know, they are, you know, allowing time for questions and those things to be raised, because it can be quite easy just to focus sometimes on this, you know, the CLL or the CML, whatever the condition is, which is important. But if you've got a nurse specialist, you can, you know, get in contact with them and raise other, you know, holistic need issues as well.
Thank you, Leanne. I think that's leading up to some questions we've got in that area. As you just pointed out, that it's great if you've got a key worker direct connection to your clinical nurse specialist or somebody on the nursing team. That might be a different issue for people that haven't yet. And you've raised doctor-patient communication, as well as kind of mixed it in a little bit there with the visible cues. I think both of you are pointing out that you need the visible cues, physical cues of in-person, as well as just trying to struggle to pick up the vocal tones over the phone to understand. So hopefully we can address that as we move forward a little bit. I'm not going to ask the question yet, how can patients help, and how are clinicians looking to help, and what you can do to help, because you touched on some of those, and I didn't do that earlier with the patient. But maybe Phyllis, I could ask you yourself from if you could ask from two ends, your experience of the challenge that your patients experience, and again, if anything you've got to add from a clinical nurse specialist point of view of how hard it is for you.
Yes, I'm the same as Leanne. I was actually running my own nurse-led telephone clinics before COVID, so I was quite used to actually doing them before. And also I used to meet the patients in the clinic face-to-face before they came to the telephone clinic. So, and get their obviously consent before they moved over to my service. So I did know a majority of my patients and see them face-to-face before we'd actually kind of moved over to the telephone service. But obviously with the pandemic, then everything changed very quickly overnight. And then all the consultants and registrars were actually doing the clinic by telephone as well. So yes, the challenges are, if you don't know your consultant, and we do pick up a lot of non-verbal cues when we see the patient face to face, and we do miss that when we are doing the telephone consultations. But I think it's important that we actually give the patient time and we ask the right questions to the patient to explore not just the condition, as Leanne was saying, and any side effects of treatment, but also how they're actually coping, and then signpost them in the right direction. And as you were saying before, sometimes patients find it very difficult with the telephone on the, you know, they may not be maybe they've got hard of hearing, or they've got a problem that they don't find the telephone very easy to converse with the doctor with. So I think that's important for the patient to feel empowered to say to the doctors, actually, I don't feel comfortable with the telephone consultation, and please, is there any possibility of changing to a face-to-face, you know, or making sure that they have a family member with them or a partner that can actually be on the consultation with them, so that they can, you know, 4 ears are better than 2. And that's also very helpful as well, because the carer or patient or partner can actually express their views about how the patient is coping at home. And so we have a 3-way conversation. And we do invite all of our patients to have a member with them if they would like, and we can have it on loudspeaker. So I think that's quite important, to give the patient the option.
Thank you for bringing that one up earlier. I think that's something we can talk about a little bit further on, but having somebody there with you is important in so many different capacities from a patient's point of view, picking up information. I see your finger up there, Stephen.
Yes, I'm just going to ask the two CNSs, from the Hammersmith point of view, they say to me, or my consultant says to me, that actually telephone calls are a bit more difficult than face-to-face. The doctor looks into your notes, reads them, looks on the screen to see what results are there, etc. Makes a phone call, no answer. They come back, go on to the next patient, and then come back, have to look at the notes, have to look at the screen again, and do the same thing. But if you're there in person, you've been checked in by the reception team, so the doctor actually knows you're physically there, and she can just call in the next patient. I don't know whether you can liaise, you know.
No, I think that's quite a good point, to be honest with you. And you do, when you can't just read one set of notes, see somebody else and then remember that information, because that's where then mistakes can potentially happen. So you do have to look at it each time. And I think one of the things, actually, Stephen, I was going to just mention after Phyllis was, and it kind of is the opposite of that in a way, where sometimes it can work where people get a little bit worried that they haven't had a phone call if the clinics are running late, because I guess if you're physically sitting in the outpatient setting, you can see how busy it is. You can say, oh, excuse me, I've been waiting X amount of time for my appointment. But when you're on the end of the phone and you're just waiting for that phone to call, you can't see how busy the department, or actually the doctors still have a full clinic list and it gets behind, and people just don't know if they've been forgotten or not. So I think that can cause anxieties as well. And that was brought out of one of our patient questionnaires. It's something that I hadn't really even thought about. And I thought, actually, that's quite a valid point once you think about it. It's a simple thing, but so sometimes we try and say to our patients, you will get a call, but it might not be at the exact same time, because it is still a clinic list.
Thanks, Leanne, and thanks.
Yes,
sorry, go on, Phyllis.
Sorry, not normally in our letters that go out to patients that do say your telephone call is at this particular time, we do say, please be aware that we may be running late, so be aware, please be prepared to that we may not be able to call you at that particular time, and it could be an hour either way, but they won't be forgotten and they'll get a call at sometimes. And like Leanne was saying, it's very easy when a patient is in the waiting area. We can often come out and say to the patients, I'm sorry the clinic is running late, I do apologize, so they could either go for coffee or whatever. Whereas you can't do that with the telephone consultations, because obviously you can't ring them and say, we'll be a wee bit late. When we do our video consultations, which we're trying to implement more and more actually at Addenbrooke's, we use a service called Attend Anywhere, and patients technically log into a waiting area, so we know that the patients are waiting there for their call, and then we accept and let them in that way.
Thank you, Phyllis. Also, you preempt so much, because
after
the last time, no, it's great, because I actually had some questions direct for you, because after the last, when you spoke there, was the non-verbal cues, obviously video we hadn't mentioned, and you just mentioned there, and there is an opportunity there for a better connection. But my understanding, and I don't know if you can allude to that as well, is that there is very little opportunity on a broad term. There aren't that many trusts that are offering video. Do you have any knowledge?
I I'm not sure about other trusts, but I know it's something that we are very keen to, and we tried to implement right at the very beginning of COVID, but obviously we had to upgrade our computers, etc., some technical issues. But I would say that we are increasingly offering our patients more and more to be done by video, so we can actually see the patient. Obviously, some people don't want to do that. Some older patients don't have the capacity to do that. You know, so there are other barriers as well to video consultations. But I think we are set in our hospital that we can offer patients video consultations. But obviously there are sometimes technical issues with that.
So from your perspective, sorry.
I was just going to say, I think it isn't always that one size fits all, as we know, like telephone calls will work brilliantly for some people, and like myself and Phyllis were doing them before the pandemic, and it worked, you know, brilliantly. And for some people during the pandemic, it'll work really well. It might be that they're at work, or, you know, they've got other commitments and they are feeling well. They know they can get in touch with us in the meantime. They might have already got to know the team, and that works, you know, really well. But for other people, as we know, there is negatives to it as well.
Okay, from the feedback, Phyllis, how do you find the video versus the phone?
Well, I prefer to see somebody, because I like you're saying, it's nice to see somebody's face, their expression, look into their eyes and talk to them while they are actually answering your questions. It makes you think that actually, you know, somebody is actually listening to you. Sometimes on the phone, you're actually not quite sure what the patient is actually doing. That I must admit, I have had consultations where maybe patients may be walking around, and I say, oh, well, actually, can I phone you back when it's a better time for you? You know, so because I'd like them to actually concentrate during the consultation rather than you know, maybe doing other things that you can actually hear. You know, so.
Well, it's positive listening to you there, but, and as Leanne just said there, and our patients on the panel, it can't be a one size fits all. No. Technology can be also isolating and restrictive. So if people haven't got that technology and can't take advantage of that, then it could be an issue too. I just wanted to flag before we move on to a few things, because I am going to want to have a discussion about the elephant in the room, which is, you know, do people have to have remote consultations? I mean, I know COVID's put into some barriers. So just before I get to that, one group that's come to mind, and it came from your discussion, Phyllis, about knowing everybody before going into COVID and being able then with sort of a switch over to, you know, your nurse-led telephone clinics. You already had, well, COVID's gone on now for 2.5 years and people have been isolated. What's your experience of bringing newly diagnosed patients into this? Obviously, acute patients are triaged, fast-tracked into the system and into in-person connections very quickly. But chronic patients like ourselves, you know, like CML, MPN, John and myself and CLL, what's your experience of remote management, and what might you have to say with telephones for the newly diagnosed? How do you handle newly diagnosed people? Do you handle them any differently? Do you have a different approach, and do you have any advice?
So we actually do offer our new patients face-to-face appointments, because it's important, for one, that they get to know the team and that they do see the medical team in, you know, face-to-face, so they can see who they're talking to. And meet the team. I do like the idea from Leanne that they have photographs on an information sheet that does go out to patients. I'd probably be taking that forward with our team as well. But we do, sometimes it depends on the situation. Sometimes you can have the quick phone consultation to say to the patient, actually, you've been referred to us because of abnormal blood results. We do need to do X, Y, and Z tests, you know, blood, bone marrow, etc. And but then we'll bring them back face to face for the results. I think that is quite important. And then once the patient is comfortable, then they can go back to telephone consultations. So if patients do require a face-to-face appointment, we do like to see them, because it's very difficult to assess even the patient's performance status just on the telephone. It is actually nice to actually physically see them, and I think that's very important. So obviously, with the restrictions of COVID, we do still see patients as we need to, if they need to be seen.
And interested, I'm not going to play devil's advocate there, as you need to, and if they need to be seen. We might have a bit of a grey area from the obviously patients that might want to be seen in person, but the resource might not be there, or is
the what? Sorry,
the resources might not be there, or it might be contra to safety of somebody. I'm sort of leaning towards that next question that we were coming to, which is, do people have to have remote consultations if they want to just have in person? I mean, what are your positions about this? Is it a myth that people have to? Should people be able to choose? Am I playing too much of a devil's advocate there? Because I know I'm not going to ask a double question because you've thrown up so many others, but have you guys got any thoughts on that?
So in Oxford, I can only speak for our trust as it stands today. If somebody rang me and they were concerned and said they wanted a face-to-face appointment, then we would convert the telephone appointment to a face-to-face appointment. There wouldn't be an issue with that from our perspective. I think if someone has got concerns and they want to be seen, then that's fine. And likely, we can sometimes do it the other way around, where I've had people where actually it's really hard to hear. They're really struggling with hearing on the phone, and then it's a bit of a safety issue that they might not be hearing everything that you've said. Or we might have concerns as healthcare professionals when we think it'd be much more beneficial to see you face to face at the next appointment. So it kind of goes both ways, really.
Yeah, totally agree with Leanne. I mean, there is the option there, and each patient is assessed on their need. And we are seeing patients face to face, and the patient can ask to be seen face to face because they may find a consultation difficult on the phone or video, and we may also need to examine the patient, so therefore the patient will need to come to us to be examined. You can't do that sort of thing over a virtual or telephone consultation. So every patient is an individual, and we review them in that case.
Thank you both for so candidly asking that. So it's a myth that people have a rigid structure. It's tailored to suit the needs of the patient. Okay. And patients, if they want something, don't be frightened to be a pushy patient and ask. Yes. Empowered patient, I think, is the word with the webinars we've been using.
Yeah.
I'm just wondering if our terrific patients on the panel have got any insights or any perspectives in this area. I know, John, you said you've got your first in-person appointment. First in-person in so many years with a doctor?
Interesting. The consultant. I mean, the thing is that I probably don't need to be seen at all. I'm aware that in some parts of the country, certainly in some parts of the world, I would have been discharged back to the GP a long time ago. I don't have any comorbidities. My situation's stable, and I find it's a great privilege to talk to the consultants who I've got to know and trust. Very comforting. It's a safety net there. It's very important. Maybe more. I don't know. It's more or less so because I understand the disease well. I understand immunology. I understand the risks and so forth. I mean, I email I recommend people get I don't know, have you give your emails out? Do you give your emails out to your patients?
Yeah.
I've got the email to my clinical nurse specialist and the consultant, and what's coming up, and I'll just sling out a message saying, I've got no surprises, I feel well, chat to you. It's going to be a short conversation, isn't it? But then I think that back along, there was three emails and to my GP, none of which responded to. And I suddenly got very anxious that actually, our local safety net was falling apart. I knew what was happening in the hospital. So I just rang and left a message, please phone me. I'm just very busy, I don't know. But I needed to know that things weren't changing rapidly in terms of support. Will I get my sepsis screen if I get a fever? Simple things like that. What I'm interested in is really whether or not we as patients can adopt telephone consultations. Does it save you time? Because in my case, I only need 5 minutes. I don't need to come into clinic. Do you find, I'm just read to Leanne and Phyllis, whether or not you find that phone consultations are time saving for you?
I don't know that they're any different, because really we should still be asking the same questions whether we see you in person or the appointment. So if the phone, I guess the only thing that's different is if you come into the clinic, you have a physical examination, which would make it, I guess, that little bit longer, the appointment. But otherwise, I think the questions that you're being asked should be the same, whether they're over the phone or face to face. And like the review of the bloods and everything would all be exactly the same.
Yes, I agree with Leanne. I think it doesn't necessarily save us more time doing telephone consultations. I think it definitely saves the patient a lot more time, because there's less waiting around in hospital. And in fact, the initiation for setting up my nurse-led clinic many years ago was the fact that patients were saying, please, I'm really well. I'm waiting around here for quite a long time for you to tell me, yes, my bloods are fine, carry on.
Yeah, that's the same as mine.
Yeah, it was a push from the patient to say, look, this is what patients would like. Please let's set it up. And it's been going for many years now. So because, yes, there are delays when patients come to hospitals for their face-to-face appointments. They're sitting around for a longer period of time. And we've also, patients, when we used to have the face-to-face consultations before the pandemic, patients would have their bloods, or some patients would have their bloods done on the day. So, and then we have to wait for the results before we see the patient. Now, in preparation for our telephone consultations, we make sure when we do ask the patients to go and have their bloods taken in advance, so that we actually have the results when we actually telephone them, which then also does save the patient time at hospital, just sitting around when, it's, as far as lots of patients are concerned, it's a waste of time just sitting there doing nothing, waiting for us.
Does it help, for example, if we as a patient, I mean, I'd say, I email in, so when the consultant or the clinical nurse specialist rings me, she knows, they're both ladies, she knows, there's I've got no other agenda, there's no other problem. So would that be helpful, that we as patients, well, maybe I'm jumping the gun here, Nick, but
that's great. To moderate.
What you think, Steve? But I mean, I just try and set it all up. I know what I want to talk about. I put it in an email. That's my lot. So when they ring, they know exactly what I'm going to hit them with, if anything at all. More difficult if you've got a complex patient and the patient's bogged down with all sorts of interactions and comorbidities and so forth.
I think you've raised a good point. I think we can come on to some of the practical aspects. I mean, I certainly relate to what Phyllis has just said. Having to put a whole day aside when you're stable to visit the hospital, park, good God, parking in hospitals. I don't know if it's got any easier during COVID, because I haven't seen one for a while, but the trouble you had to park, then you've got to queue in one queue to take your ticket, to go to phlebotomy, to give you blood, and then you go and sit in the waiting room. You can sit in the waiting room for some time whilst you're waiting for the bloods to come through, as Phyllis was just saying. And then the hospital might have a policy of keeping you moving. So you almost move in a circle. So it looks like as you're being triaged through the system. But I can totally relate to that side. I'm just before we move on, I've noticed, Steve, that you've been nodding away and you haven't had a lot to say. I'm just wondering if there's anything you'd like to throw in before we move on to some of the practicalities of and how we can make best use of this time for both parties.
Oh, yes. I mean, at the Hammersmith, we're categorised into Category 1, Category 2. I don't know if there is a Category 3, but Category 1 patients have to be seen. Category 2 are those that can do a phone call or a video consultation, but it does then say, if you prefer to be seen, then give us a ring. Now, a few of you have been talking about, you going to places to have your bloods done and then have it ready for your clinic. With CML, we need to have a PCR test. Not very often do GPs do PCR tests because of the time delay. So we've got to go to a hospital anyway. So I find it convenient just to go to the hospital, have my bloods done, which is done in the hematology department. The phlebotomy for hematology is all there. Sit and wait. I get a ping on my phone to say that my full blood count and everything is already through, and I can view it there and then. And then I'm called into the consultant, and we discuss well, in my case, problems or change of medication, which I've just actually done two weeks ago. So from the blood point of view, I have to go to a hospital anyway, so I might as well do it all in one hit.
And sorry to be naive, you're visiting in advance for your bloods, or you're able to do it on the same day at the unit, because phlebotomy can turn that around actually at the hospital.
I do it on the same day.
Right.
The only result I don't get, but I get that by email 8 to 10 days later, is the PCR test.
Whereas if it was an FBC test, a full blood count, that could be done by the GP and with any other tests. I get your point.
As I'm going anyway, they can just do the whole lot, whatever they need to do. And as I say, within 15 minutes, I've got the full blood count on my phone, which I find very helpful. In fact, they have a system where you can see all your appointment notes, all your clinical notes, all your appointments, all in one place. So that's a very useful app that they have.
That's really interesting, because I learn something every day. It comes back to what Leanne was just saying there. One size doesn't fit all, and there are many different types of blood cancer patient, and people live different lives and have different things. So it's really reassuring. And thank you everybody for having this initial discussion. I'm going to play devil's advocate before we move into the question of what can help a call go well, and then look at all of the different practical aspects that can help with that. What can, from your experience, what can make a call go badly? Now, you've already mentioned one, yeah, which was delayed telephone appointments and people not being there at that time, rather than because of that from the clinical end. And I've got one to come back on there from the patient's point of view, is our own forgetfulness and not being available for the call when it does come through. But so the call never even happens. But are you able to share any insights from the patient perspective first? Yeah. What can make a call go badly for you, so that you're not getting out of your call what you might have wanted or expected? I guess I'm playing devil's advocate by just raising those spectres so that we can actually look at the practical aspects as we run through how to get the best out of your call. Any thoughts? Any experiences of calls going badly?
Not being prepared, for one, forgetting your appointment that somebody's going to ring on that day anyway, and being not prepared, not having written down your questions, what your thoughts are, that could go very wrong. And then, after you've put the phone down, you suddenly think of the most important question you wanted to ask, and you now have to wait or email or do whatever you need to do, contact your CNS. So it's always best to be prepared, have the date firmly in your mind, and make yourself available for that call. If you're in the middle of a call center or something, it's no point taking the call when there are 20 or 30 people speaking around you and you can't hear what you're saying. So excuse yourself and go to the coffee place or whatever to be able to take the call. It's just being prepared for it.
That's magic, Steve. Sorry, Stephen. Two answers. One, what can make it go badly, and what can help, and definitely add that now to come back to. John, I know you could probably answer the question with two heads on, but answer it with your patient head on, because I know you do have thoughts in this area sometimes.
I haven't had a bad telephone call. Partly probably because I'm very used to telephone consultations, and it's a very familiar environment for me to be in. I think I tend to I find myself driving the phone call rather than the consultant driving me, but I kind of know what they want to know, and I don't want to waste people's time. I think if you start having to take notes while the telephone consultation is going on, I think then it could go very wrong, because then you're not concentrating, or the person on the other, the doctor or nurse on the other side probably will hear that you're not quite sort of going with the flow, And I think it's really important to have somebody alongside you. I mean, going back to what we said earlier on,
That's what Phyllis was
during the
pointing out, yeah.
consultations, take notes. It's an anecdotal thing. I mean, my wife many years ago had breast cancer, and we had a very 1 hour long consultation. My wife's a busy medical ward sister, nurse, very familiar with medical stuff. And I was a doctor, and we had a consult. We both went to her consultation with the oncologist way before my diagnosis, and we came away, and both of us had very different memories of what was said. And we almost had a kind of disagreement because we said something. So I think, and then you have the problem yourself. You think, well, what was said? No, did I remember that right? And then you get the anxiety creeping in, and it can be counterproductive. So I think, I don't know what you think, Steve, I think to have somebody. I mean, I used to tell patients, take somebody with you who you trust with a notebook and pencil and paper. Ask them not to contribute or interrupt, but just take notes for you. And I think that's very useful, particularly if things are getting complicated.
Thanks, John. That's a really interesting insight. So having to direct yourself to multitask and try and take notes and listen at the same time doesn't work. And it's reiterating what Phyllis was saying very early on. So it's really interesting that that's come back straight away to the fore. I'm going to ask our clinical nurse specialist what makes something go badly for you from your experience, because it can, you're doing a job, you've got a massive list to get through, you've got every booked in, and you're trying to give the best for that individual. But where are the, what can make things go badly? And then we'll lead into the questions about what can patients do to help, and also what can patients do to help themselves as well, and the practical aspects of helping to get the best out of the call. But I think I just want to ask you guys to raise any spectres you might have. One of them you raised was from your end about having to delay calls. But I'm just wondering if you can be objective of a bad call that's not necessarily initiated from your end.
I guess things like, again, like Stephen and Jonathan, make sure you prepare for the call. If you haven't had a blood test done, obviously we can't give you all of, from a CLR perspective anyway, we can't give you all of the information, and then we would then have to call back again. Having a bad reception, just simple things where, I don't know if you've heard me properly and I can't hear you properly, again, because that's like more of a safety thing. So we don't know on either party if we're hearing the right information.
I think that's right as well, but also being kind of a quiet and a private place is quite important, because there are times when you're talking to a patient on the phone, you can hear, maybe they might be washing up in the kitchen, or you can hear people in the background, and that makes it difficult to hear. So or being in a noisy cafe, or so you do want somewhere quiet where you can actually hear the patient properly, and that they can hear you properly, and not being rushed. Hopefully that the person doesn't kind of book another appointment straight afterwards where they're rushing. Sorry, I can't talk to you now. All's fine, I'm going, whatever, or whatever. You need time to give yourself time to have the consultation with the patient on the telephone. I mean, and for the patient to have time to talk to the doctor on the phone, or the nurse on the phone.
It's both parties, and you could be challenged in the nursing environment to be able to find that clear space and the desk and the time and headspace, and likewise for the patients. That's a really interesting answer. So let's move on to a positive approach.
Just say one thing before we move on about time. But pre-pandemic, I know a lot of my patients would have various different clubs that they would go to during the week. So they would either say to me, well, I've got a commitment, say between 9 and 10, so please make my appointment later, so again, talk to your patient to find out what commitments they have, and that it's a good time for them, and that they will have time, so that's important.
And that's something that patients should think of themselves to make sure that they've allocated that space in their activities.
I normally ask them when's a good time. Do they want an earlier or a later morning appointment time to fit in around their activities?
Yeah, it's probably been easier during COVID, when people have been a little bit more confined to quarters and haven't been able to be in work and or be in the gym, and multitude of things. But yeah, and I
guess with the doctor's list, sorry, that might not, like with my nursing list, I'm very flexible with it, but with the doctor's list, I'm just mindful that, yes, we'll try and accommodate that, but it might not always be, if they've only got an afternoon list that week, for example.
Yeah.
and there the structure's a lot more rigid.
Yeah.
Doctors, yeah. So if you haven't complied as a patient, do you get put on the nurses list? I just wonder myself, actually, because these days I'm on the nurses list, and I used to have terrible problems getting my bloods in time, and I wonder if that was
no.
It's all about how stable you are and how you know, and the complexity of your disease as to whether we used to move over to the nurse-led service rather than medical service.
That's an interesting point you just raised there, because, you know, if we looked in CLL, for example, at watch and wait patients, the distance between before remote consultations, the distance before your appointments was always an indicator of how stable you were, and it can take some time to understand that. Is that are the frequency of appointments the same as they would have been from a physical point now with more telephone triaging? So do you talk to your patients in the same frequency as you would have done before? You know,
I think if you're stable and you've got like no alert symptoms and your bloods are all stable, I think it's probably the same. I guess if there's flags coming up, then we would more likely be seeing you face to face and bringing you forward anyway, which would be what we would have done, I think, before the pandemic. But I guess the only difference might be if you've had a telephone consultation with a doctor and they've got concerns from what you've said, what they might say is, okay, next time we'll see you in, I don't know, in X amount of weeks, and we'll see you face to face and bring the next consultation forward that way. I don't know if you agree there, Phyllis.
Yeah, definitely. I think the interval between seeing patients is the same kind of now as it was pre-COVID, but also patients do know that they have our contact number. If they have any concerns in between their appointment time, that they don't wait for their appointment time and that they contact us with their worries and concerns, so we can talk to them in between and then bring them back earlier if we need to.
I think one of the problems about, which I've heard quite often about having telephone appointments, is medication. It's, you know, if the frequency is not as it was, you know, instead of making it every 8 weeks, now it's every 16 weeks or something, people are then getting very frustrated that their medication is not arriving, or, you know, panicking that, you know, they're down to 3 days medication and nothing's happened. So I think there is a little bit of margin of error there by having a telephone conversation as opposed to a face-to-face, where, you know, you can physically say, you know, I need a prescription, you know, can you give it to me, or would you send it off for home delivery, etc., etc.
I guess the key thing probably again is the communication of making sure that on those calls we're having a look at when the next prescription's due, having a look if the next medication's prescribed, and making sure that pharmacy know to screen it and when the medications are due for as well. But I completely hear you. It doesn't always all tie up, and I completely understand it causes a lot of anxiety when it doesn't as well.
Really interesting insights, and I would just wanted to say before I moved on, you know, talking to a clinical nurse especially, this isn't like being put on the naughty step, I didn't mean it in that way. I'm really pleased when I've got my connections with clinical nurse specialists, because I know you're geared up to that element of holistic care and support and understanding the deeper needs of a patient. So I just want to thank you guys for that one. I wasn't being contentious in there. I'm just thinking maybe we can do a little bit of a whistle-stop tour then through all of lots of different practical aspects, and maybe we can then sort of finish with a bit of a checklist that people can take away with them. And then so forgetfulness was brought up earlier, and I'm looking at approaching this from a practical side. I've got a question here: what can help me with forgetfulness to ensure I remember my appointment, and what should be done ahead? And there's lots of different sections of that, but have anybody got any suggestions?
That forgetfulness during the appointment, or forgetting that
sorry, I'm going to split this into 3 sections. So let's cover planning ahead, topics for discussion before a consultation. So it's forgetfulness there. I mean, I know from the clinical side, you obviously have letters and other notifications that come through. And I'm just wondering from the patient's perspective, what do you do to make sure that you are there at the time you're meant to be and you've allocated that time? Any suggestions?
I get bombarded with text messages, and there's always that. Is that what you mean, Nick? I mean, it's very hard the way things work here to actually miss a consultation. You have to ignore probably three. I mean,
What about
yeah,
if
I suppose
you've got
between
bloods, if you've got to have your bloods in the community, and obviously then it will.
Well, you know what I do about my bloods, Nick. I better not advertise that.
No, we can't
publicly,
advertise that. That you, yeah, as a doctor you can.
but
not.
yeah, I mean that's
Setting
the problem.
reminders on phones. I don't know if that would work. So if it comes up as an alert, if you've got a smartphone, maybe.
Exactly. I mean, there are techniques, aren't there? To what do you do, Steve? Are you very organised?
Well,
You've done it for a long time.
I live my life by my diary, so
Yeah.
a paper diary, and I have my phone diary, and so I know when my Hammersmith day is. And yes, they also they don't send reminders actually for clinic appointments, whether it's phone or otherwise. But again, I can go to the app, and I can, the first thing that you do or you see when you open the app is your next appointment. So it's all there, followed by the last clinic letter. So you know it's a very technical technological way of doing things these days, and I've got multi areas to see that I don't miss the appointment.
What we've started to do.
And a wife.
I was going to say what we started to do during COVID, because we did find that a lot of people have been forgetting to have their bloods done, as Leanne mentioned earlier. So we now text our patients beforehand to say, just a reminder, please have your bloods done in preparation for your appointment on this date. So there are some patients that do need to have their bloods taken at Addenbrooke's, and then they are booked appointment times now, rather than previously patients used to be able just to walk in, pull a ticket and sit and wait. We don't necessarily do that now. There are some urgent cases where we do have those slots, but the majority of patients have booked appointments to come and have their bloods taken if they needed to have it taken at a hospital, so that they're not sitting around waiting as long as what they used to have done pre-pandemic. So they have an appointment time, they come in, they have their bloods done, and then they go. Patients that do need to have their bloods done, either at our drive-through service or at the GPs, we send them text reminders to say, please remember to have your bloods taken. That helps. It has helped.
It sounds as if everybody's suggestions would help, but the responsibility, if we've got those dates and got that, is down to us to make sure we do to get things done if we can. I know it's been difficult during COVID. Otherwise, it can make the call. You can't have a discussion about where your bloods are, and if you're looking to renew medications, they can't be, pharmacy won't prescribe without the new bloods. So that's something that we've got to take responsibility for, as long as we get the information. It would be
we have a new service. Oh, sorry, we have a new service which has set up purely during the pandemic here in Cambridge. Is that we now have a drive-through service. It's very similar to as you would go and have petrol. It runs at one of our park and ride services, where patients can drive in and they give the phlebotomist their hospital number. Their bloods are already on the system. They put their arm out of the car, they have their bloods done, and they drive away. So, and they don't need an appointment for that. It's a 9 to 4 service, and they can come any day, Monday to Friday. So that's something that was started up because we wanted patients. We were trying to decrease the footfall here at Addenbrooke's, obviously because of COVID during that time, and patients were having difficulty having their bloods taken at GPs, and we found it's working exceptionally well. Patients do like it, and we have kept this going.
That's well, it's a terrific service, and it's a great suggestion. I'm going to look at lots of different practical ones. So we talked about periods between appointments, and there can be long periods between telephone appointments. And I don't want to open a can of worms with some great long descriptions of some specifics, but I was going to ask our clinical nurse specialist first. What should people keep a record of before their next appointment? What's important for you that over a time that you don't see them, that they're keeping a record of? And then from a patient's point of view, what have you found is important to keep a record of? I think one of the things we discussed about, I don't think we had actually, but one of the practical things that before your next appointment is keeping a record of your health issues you might have, things of that nature before your next appointment. So if I didn't ask the question, I apologize earlier, but what I was going to say is what's important to you that people share with you and that you feel that they should keep a record of before their next appointment?
Oh, well, there's lots of things really, and some of them are very disease specific for various different patients, but basically how the patient has felt from the last consultation to this consultation, any new signs and symptoms that they can be concerned about, any side effects to their treatment, any new visits that they may have had to their GP for new conditions that in addition to what we're actually seeing the patient for, any change in their medication from the GP, whether they've had any new symptoms like maybe weight loss or night sweats, which is new, or increased fatigue, or any new lumps and bumps, or any bruises, bleeding, or anything that they're concerned about at all. We do like to hear about any recent infections, any temperatures, coughs and colds, things like that, really.
That's really helpful.
I think if the patient, what I find anyway, personally for me, is that if the patient doesn't come or doesn't offer any of these symptoms that I might be looking for that might make me concerned about the patient's disease, but then I will ask specific questions related to maybe their weight loss, their diet, any night sweats, etc., various different things that are particularly important for that patient's particular disease. That would make me worry that maybe the disease is changing in some way.
Thank you, Phyllis, because human nature is, as human beings, if we had a cough, a snivel, or an issue, a symptom 2-3 weeks ago, we move on quite often as patients. So if you don't record them, and if you don't keep a record, then that can't be shared. And you've done it again, which is brilliant, Phyllis. You moved straight on to my next trigger question, which came from Leanne, because Leanne, you mentioned, are there physical triggers that you want to know, that you would want to know? And I guess, as Phyllis just pointed out, some of that is disease specific.
Yeah. I mean, I guess if there's anything particularly concerning going on, like Phyllis said earlier on, don't wait until that clinic appointment. You need to be ringing the clinical team beforehand, or the triage units, whichever's more appropriate. But generally, I mean, from a CLL point of view, we're looking out for what we call the B symptoms. So like Phyllis was saying, is the weight loss? Are you getting night sweats? What's your appetite like? What are your energy levels like? Have you got lumps and bumps, but in like a large lymph nodes? And generally what your overall health has been in between appointments. And sometimes things like fatigue can be really hard to judge it, and it's quite subjective, and people don't always notice that it's worsening over time. So maybe just sitting just for 5 minutes thinking, can I do now what I could say 6 months ago, or are things becoming more challenging? Sometimes people are struggling to remember when they've had antibiotics and what for, or whether they were treated with 1 course of antibiotics or 2 courses of antibiotics. So just little things like that can be quite helpful. So we know, how you are doing from an infection point of view. And particularly if you're on treatment, there's some medications that can interfere with treatments that you're taking. So again, like Phyllis was saying, making sure you've got an up-to-date list of your medications with you is good as well.
Wow, that was really helpful, and you kept a lot. I'm just wondering from our patients, have you got any thoughts in this area of things that you find it's important to, from a practical point for yourselves, to keep a note of?
Well, things that we're asked constantly is weight loss or weight gain, because the CML can, in its initial stages, can make you lose weight quite rapidly, but the medication can actually make you gain weight. So it's important to have your most recent weight with you when you're making your phone call or having your phone call, because that can be a precursor to, I don't know, fluid on the lungs or edema somewhere else, etc., which you wouldn't think about, but it's important for the consultant to know about. So weight is
and that's something you keep a note of. That's an interesting one. I miss it actually. My physical appointment every 2 or 3 months. You know, as you're being moved through the system, having called into the office to stand on the scales, and I can't recall the last time I was asked how heavy I was. So that's an interesting observation. John, anything from a practical point? I'm mindful of time, and because we could go on forever talking about lots, but I'm going to do a whistle-stop tour through a few other topics. Have you got any thoughts? What you feel is important to note down as a patient that's helpful for you?
Yeah, I mean, obviously, as a GP, I mean, I learned that a lot of GPs don't really understand CLL. I certainly learned a lot more about it than I knew when I was working. And self-advocacy, taking responsibility for your health, I think requires a certain learning and understanding of one's condition. And watch and wait before, you know, I learned a lot about CLL, all the questions that I was asked repeatedly leading up to chemo. So those are the questions that, you know, are logged in my mind, are the ones that have already been touched on. And that, you know, the one question that I get nagged about repeatedly by my hematology team, I probably know why, is infection. Maybe they're worried that I won't come in if I get a pyrexia or try and self-treat or something. Maybe that's fair enough. But I think that one of the questions I have now is, how will I know when I relapse, if I am going to relapse? And of course, I know the answer. It could be one of a dozen different ways. It could be weight loss, weight gain. It could be, you know, your lymphocyte count going up, or some other secondary hematological complication. So I think these are really important issues that, I mean, I record everything that happens to me in a diary. I have an Excel spreadsheet type diary. And if I have new symptoms or odd things that happen, I will log them down. I had pain behind my left ear 2 weeks ago. I've never had before. I developed visual migraine back along, which was completely out of the blue. I don't get headaches. And I record all these things. I don't know if they're going to become important, but they might be. So I think it's about taking that amount of responsibility, using a diary. And I have a bespoke diary, as it were, for CLL. It's a bit bare at the moment because things are going well, but I think they're really important. And then when you can feed back to your clinical team, hopefully you feel that you're getting a authoritative, you know, concise, timed, which is also very important, account of what's been happening. It's a complicated disease, you know, it's heterogeneous,
and we're all very complicated.
We're all different.
You're all different, and some of us want to know more about it than others, and some
there's a lot to be said for learning. I don't know what you guys think, but learning, us as patients, we can learn a lot about our condition, which will help us.
I think that's an important point. I agree with you that, you know, an empowered patient, if you've learned a little bit about your condition, you know more about your condition, then you're more able to engage and know what to look for before your appointment. So Leanne, I noticed that you
yeah, I was just going to say as well, just writing all your questions down in between appointments and either feeding them back to the clinical nurse specialist if you've got one, or the medical team in between appointments, so you're not worrying between the next 6 months. Or, you know, sometimes you get your clinic letters and the terminology you might not always understand, and again, just picking up the phone and ringing saying, what does this mean, and, you know, what do I need to look out for? Is we much prefer you to ring and ask and be clear than be sat at home worrying, you know, in between appointments and not knowing really what it means. Or, you know, sometimes people worry about the significance of blood tests because during the appointment they might have been told that, you know, it's only a small change, but then they might go home and then worry about what that means. And again, that's fine to pick up the phone to your medical team and just talk it through again, so that we can explain what we're looking for and, you know, what we would then deem to be significant and why we aren't acting straight away. You know, just those little things that can make a difference between appointments.
That's really helpful. And I was going to say, Stephen, if you sorry, go on, Stephen first.
I was going to say, I second what Leanne was saying, and really just to say that there's no question that is a silly question or a stupid question, and or the fact that you may have asked it before. We are very happy to go over things again with you, and so please don't think, oh, this is a silly question, I'm not going to ask. Because you will be worrying about it. So we would rather you would phone us so we can have the discussion with you and put your mind at rest, or yes, that's an issue, we need to see you.
Right, that's really helpful. You've done it again, Phyllis, which is perfect. I am going to come to you now, Stephen, really quickly before we.
Yes, very quickly. I think something handy to have nearby is a list of acronyms, because people throw out, BCR-ABLs, PCRs, FBCs, and in the early days, you don't know what any of these things mean. So if you can just have a quick look, full blood count, polymerase chain reaction, etc., with the little explanation by it, it's much easier, because some patients don't want to feel daft asking what does BCR-ABL mean, or they've never heard of it. And I think, just to have that little thing, and I know Leukemia Care in most of their booklets at the back have the listings as well. So that's very, very useful to have.
That's a really important observation, and it was one of the questions that I wanted to come to, is how can we deal with that? And I think John raised that learning helps. Learn about your condition, use the booklets that are there for you so that you've got a bit more understanding, because that can help dampen some of the fires of anxiety if you actually understand what's been discussed. I'm going to leave this section about preparing on one, because both Leanne and Phyllis have been talking about there's no such thing as a stupid question, and about answering questions again on the phone. As an advocate, the most common question I get asked is, what question should I ask? So I'm just wondering, are there questions that you found as experienced patients that's important, that you find it important to ask at your visit, or are you so settled now that so I wanted to just raise that, because I've got quite a few questions that questions about questions. What are the important questions to note down? What's important for somebody newly diagnosed? What should they? That's one of the most common questions that we get. What questions should I ask?
A power question is to ask your clinical nurse specialist or consultant: are you worried about me at this time? Are you going to worry about me as I walk out the door? No. See you in a month's time. It's quite a reassuring. I mean, maybe if they pause there, they maybe they haven't told you something, but I think knowing that things are in the clear, go away for a month or 6 weeks, 2 months, and live your life, which is what is really important, and live the moment. I think is to get a confirmation from you guys that we're actually okay at that point.
That's really helpful, John.
Reassurance is a big topic anyway in itself, but to be told in very simple words, you're okay at the moment. We know it's not going to stay the same, but go away, you'll be fine.
What's my treatment plan, and what if that fails, and what are the other options? Are questions more for CML patients than they would be for CLL, because a lot of those are wait and watch.
Absolutely. Any thoughts, clinical professional, clinical nurse specialist? Yeah. The type of questions if you could empower a patient to ask you the right questions that could help reassure them and help them move along the journey.
I'd say, like, what alert symptoms should they be looking out for in between appointments? What practical information can they do to help? So things like vaccinations are quite important. Having the contact details of your medical team, so you know who to contact should you have any questions. And again, contact numbers should you run into problems and maybe feel unwell and you need things like triage numbers in between appointments, just safety net information really, so you know who to go to in between those clinical appointments, whether they be face-to-face or over the phone. And support services like yourselves as well. Where is the help that's out there to support me through this? Where do I go for extra information should I want it?
Thank you, Leanne. That's also really. So Phyllis, anything to add before we move on?
Yeah, absolutely. Exactly what Leanne was saying is really important. Do like to red flag the patient to say this is what you need to look for in between appointments, and if you're concerned, please contact us. One of the things we also worry about with patients who are on hydroxycarbamide, which I know a lot of your patients may not be, or will not be, but some of the MPN patients will be, is any development of any leg ulcers, which is really quite important. We basically say, please don't wait until your next appointment. You must contact us to let us know. So it's letting them know the important things that they need to contact us for that are specific for their disease and their treatment. So
from a question, rhetorically, the patient should ask, what are the most important questions I should ask you if I notice anything? Yeah. I was going to ask the question, what should I have to hand before a call? Because those are quite practical, but I've got a little list to summarize at the end. So if I ask that question now, we could probably chew up 5 minutes going through what's important to have to hand. I was then going to progress some questions very quickly about during the call and then summarize follow-ups. So I'll come back to that at the end and just offer out the lists that we've got and the resources that are available to help people with this information. And maybe I could ask you all to if there's anything missing off that you'd think to add. So let's move on to, you know, I mean, what's become clear, preparing for your call is probably one of the most important aspects of the call. That's summarizing where we've just been at the moment. And the information you've just given is terrific. During a call, we've touched on making space for that and concentrating. I noticed a comment from one of our audience around that, receiving calls at work. You know, is that conducive really to be able to concentrate on your call? So what can help with concentrating and keeping focused on the appointment and on my own issues? I think we've probably covered that with regards to making space and time. Phyllis, you were quite clear on that. Has anybody got anything to add that can help you when you're concentrating, you need to concentrate on your call? And John's have very helpful reiterated what Phyllis suggested about making sure you have somebody with you, because then you can concentrate on your call if they're taking your notes. Has anybody got anything they'd like to add in that area?
No, I think like it's already been said, just a quiet space where you're not being rushed for time, maybe a pen and paper to hand if you want to drop numbers or, you know, anything like that down. But I think just being in the right frame of mind for the call, really in a quiet time, is key.
And again, I've got another question at the moment, was what, it can be difficult on the phone to hear without visual connection. What can help? I think that's in that same area. So I think we've kind of covered that. What can help with confidence and being clear about what you want to discuss? I guess we've also covered that in terms of a bit of education, self-education, understanding a bit more about your condition. And have you got anything there that can help people, any suggestions that can help people with their confidence to be more involved in their discussion?
I think just not being afraid to ask. That appointment is your time to, you know, you would need to get the most out of it, really. And if you do walk away and you didn't want to ask the question, then again, if you've got a clinical nurse specialist, you can, or it's something you've forgotten, you can get in touch with them afterwards. We much, like Phyllis said, we much prefer to have the questions and you'd be clear on what's going on.
Interesting, because my next question was to ask what can help me understand and be clear what I'm being told. So you need questions after questions, questions after answers. Don't be frightened to ask a question. No such thing as a silly question. Yeah.
No such thing as a silly question. Absolutely. Yeah, and for us, it's to make sure that we give the patient time to answer the question and to think if they do have any additional questions. So no matter how busy we are, we need to make sure that we do give the patient all the time that they need. And sometimes if the patient's not very clear at kind of expressing themselves, by us asking, you know, direct questions around their disease and their side effects and things, that can actually make them think and make them, you know, oh, did I have that problem or didn't I? Or no, that's all fine. And hopefully by our questions, it puts them at ease. And again, like I say, no question is silly. We would rather they'd ask the question rather than not. And knowing they can contact us in between is so important.
I think you should empower yourself as a patient. It's your body. You're talking about you. You're not talking about a person next door. So you want to know what your prospects are for life. Where do we go from here? What do we do? It's your body. Empower yourself to get the right answers. They just won't fall off a tree. You know, the piece of paper will tell you. You've got to know your body, know your mind, and ask the right question.
And that's something that can come with time as well. Obviously, with time, with a chronic condition, you begin to understand more of how things are reacting to you. But even so, if something's not right, what you're saying is, and I use the word pushy patient rather than be empowered. If you aren't empowered with knowledge, learn if you can, but be pushy. don't be frightened of asking the questions, is the feedback that's coming back there. Yeah. Any other
And
thoughts?
also, if you find, apologies, also if you find that you are someone who is very nervous and very concerned about this, making sure you have a partner, a husband, a family member that can kind of ask those questions for you and understand it for you if you feel it's too much for you. If you have somebody that totally understands and will talk on your behalf, I think that's important as well. We're happy to have that conversation.
Yeah, so it's not just a note taker, your other party, that if you want them there, that they can play an active role in helping you with that. So again, we can't reiterate enough how important it is to involve a close family or a friend or somebody that's able to help you. Yeah, that's really, really insightful. I think we covered a lot of it in the prelim as we were running up to it. I'm mindful of time. We've got 10 minutes, which is a long time. Can we have a look at where do we go after a call? And I don't think there are too many questions here, but in terms of how I've got a question, how do I ensure that the next steps are clear for me, and what should help? And I know from the clinical end, you provide information, but maybe you could, how do you want your patients to leave with regards to being clear about their next steps? And from a patient's point of view, what do you do to make sure you're clear about what the next steps? So we'll ask our CNSs first.
So I guess before somebody either leaves the clinic room or their phone calls ended, it's good to just check in and just maybe summarize with the plan at the end, or make sure that the patient's happy with the plan. But also the clinic letters that get sent out, after every consultation, hopefully are quite clear as well, with capturing what was discussed and then again what the plan is and when the next appointment will be. And again, I know I keep coming back to it, but if you're not sure, you just go back to your clinical team, you pick up the phone and you ring, and it can be talked through again.
And also to know that if we want our patients to have some bloods taken before their next appointment, we will basically send the patient their pack and their blood form, their blood bottles and blood pack, unless they're going to go to Park and Ride or come to Addenbrooke's. It's making sure that we get the bottles out to the patients for them to take to the GP. And then if it doesn't arrive, then again, if they can contact us to say, my blood pack hasn't arrived, please send it. So making a note in their diary for when the next one should be, that would be important as well.
Okay, and from that is consultation follow-up letters. Is the GP normally copied in as well as the patient?
Yeah, that should be automatic.
Should be. So if people are noticing their GP's not contacted, they need to just raise that. Quite often I find a problem when visiting the GP. They probably don't read the letters, but sometimes they don't pick up when they've got follow-ups.
I'm finding that doctors, GPs are being circularized, but the patient is not receiving the letter.
Aha. Okay. So the question is from our clinical nurse specialists, patients should, and they should be able to request that they have that notification. So if you're not, the point in that one is make sure you raise that.
Yeah, the same letter should go to both the GP and clinical nurse specialists, and the patients as standard.
Okay.
Yeah. And if it doesn't arrive, please contact us so we can make sure it gets to them.
Well, I think we've covered so many questions because they become repetitive. We come back to the time in between appointments. Who can I talk to about issues of my experience before my next appointment? We've already said, you've already covered on that. Get on the phone to your CNS, drop an email, get in touch. Who can I talk to if my appointment has left me feeling distressed or uncertain? I guess that could be slightly different. You can reach back to your healthcare team for qualification to let them know. If you're having difficulties there in that area, you can reach out to a third party, talk to the charities. Advocacy can help with that if necessary, if you've got barriers to overcome. Anybody got any thoughts in that area? If appointments have left you just feeling totally distressed and you're not, I mean, I wouldn't expect it to be the norm.
What about your GP? I was sticking my neck out.
Yeah, well, there you go. There's another part.
We haven't really touched on this, and it's something. I mean, I could not the time now, but for me, there's a real issue here. What's the role of the GP? in managing, say, CLL? Big question. I don't think my GP really knows. I've got my ideas, but the GP's there. You're
The GP is responsible for your holistic care,
and they because you've been looked after by the hospital,
yeah.
they don't relinquish medical responsibility for you. So go to your GP. I know it's tricky at the moment for all sorts of reasons, but
my GP said I was their fifth ever. Sorry, my GP didn't have a CML patient originally, and when I went to my local hospital, I was their only fifth ever patient with CML. So I think when you're looking at these sort of diseases, we tend to be more advanced than they are on the knowledge of each. You know, they're good at hematology. Oh yes, you've got this, you've got that. But when you break it down, they're a master. What is it? Jack of all trades, master of none. So I find that I'm better. I have more knowledge than my GP on CML.
And that's nothing wrong with that, Steve. There's nothing wrong with that.
Absolutely, that can be challenging, and quite often you can feel that. But I hear where John was coming from there, that GPs are responsible for your day-to-day health needs. And if you're feeling anxious, emotional, or you're challenged, or you're distressed, and you can get help from your GP in that area. So well done for raising that flag.
And I think it's important that the GP is. Oh, sorry.
Go on.
Sorry, I was going to say the other important. Sorry, the other thing that's important to say is that, yes, some of these are rare diseases. So yes, you're right, the GP may not be an expert in it, but also a lot of patients do have other comorbidities, which GPs are looking after and which GPs are very knowledgeable about. And they can always assess the situation. And if it is another thing that's causing a problem and not maybe, your hematological problem, so GPs are very expert at that. And if they were concerned about your hematology condition, that they would actually contact us as well.
I was practically just going to say the same thing, actually. And one of the things that I often say to people is it's hard sometimes to unpick if this is CLL related or if it's related to something else. So I'll often say we'll come at it from two angles. We can assess it from the CLL point of view and the GP can assess it more broadly, as it's very easy to say, oh, yes, it's all this. And then it could be related to something else or another health condition.
It's a very, very important point. And GPs are very good at navigating through areas they're less familiar. They've got lots of roads, less traveled roads they go down. I consider myself still, expert at managing, complex conditions with minimal, input and knowledge. That's what we do with generalists in the ultimate sense. So I think the GPs still have an important role.
Absolutely, and I think all too often we it's easy to feel that everything's down to your hematological diagnosis when it could be down to a multitude of other day-to-day scenarios. So that's a really great way to leave from this point. That remember who your resources are. If you're unsure, ask questions. Go back to your clinical team. Ask questions after answers after questions. You've got your GP at hand, and you've also got the charities as well as to reach out to, and they can also help maybe mediate or overcome or give you information. And information is king from a point of view of empowerment. That also helps. So I've learned a massive amount. I'm mindful of time. I've got 2 minutes. We've got 2 minutes. I've really got to thank our terrific panel. I've got a checklist for patients. What should you have next to you for next appointment? And I put a link on the slide, which I'll come to in a second. But some practical sessions, keep your phone on loud. Make sure you're these are summarizing from other things we're talking about, be in a quiet and private location. Thank you, Phyllis, for raising that one. If you wear glasses, make sure they're clean so that you can read anything that you have if you're on a video. If you're not taking notes, don't take notes yourself, have somebody with you. If you wear hearing aids, make sure you have hearing aids. These are pretty practical, but help with concentration. Make sure you've got your list of medications to hand before you call, including those not related to your blood cancer, as we were just talking about there. So make sure that, because quite often you'll be asked for those on your call. Keep notes of any symptoms in your diary, as we've just discussed there. So keep a record of those in between appointments, because that's important information for your care team. Make sure you've got a pen and paper to hand. And if you don't want to take notes yourself, because it will spoil your concentration, make sure you have somebody with you. Any medical letters or results you've received in the past, quite often might be a good idea to have those to hand or to go through those before, just in case they've raised any questions that you've forgotten about. You can discuss them then in your consultation. Details of any appointments you've had with other medical professions since your last since your last consultation, so you can share with your care team if you've got any other issues going on and you've had to see other doctors, they'd like to know about that. A list of questions you want to discuss in the consultation. We touched about that earlier. What are the right questions? There are no right questions. They're your questions. So, you know, just if you've got questions and they come to you weeks before, months before, jot them down in your diary as well. See if you can bring your questions. Have those to hand, because the most common thing we all do as patients, we go into an appointment, we forget the questions we have, and we leave with those questions still in our hand. And your diary or calendar is one of your most important friends for your next appointment. Anybody else got anything they'd like to add as things they should have to hand? Very quickly, and then I'm going to try and share some slides. I'm taking that as a no. Yeah. Listen, panel, you've been terrific. It's been a real privilege chatting with you. I've learned loads, and it's so great we're able to come together, and thank you everybody in the audience. I'm just going to now and see if I can share screen, and I'll just run out with some slides with you. I believe this is happening. I now have to find these, apologies. Aha. Sorry to keep you all waiting. Okay, just following up after the call, services available from Leukemia Care. Please do reach out, watch future webinars. I hope you find this webinar very helpful, and you can also revisit on the website and look at the video. We offer a service of podcasts, which cover a range of topics as an alternative to webinars. These can be quite useful because you can listen whilst you're doing other activities. You don't have to sit and focus. You know, if you'd like to get more information, as well as using the website for information, you know, drop us a line through the website to, you know, for permissions to receive the newsletters, and we provide a quarterly magazine, which is incredibly important. I'm just going to leave this on the slide here. On the website, there are information to cover everything that we've just discussed. So we've just been through the topics today: preparing before your consultation, during the consultation, after your consultation, and a checklist. That's available on the website, and I have the link here. Next webinar is tomorrow. What can help when talking to others about your diagnosis? That's quite an important topic, because it can be very difficult and challenging to talk to close family, friends, other stakeholders. This might be an interesting webinar that you might find very helpful. You can register for that online. If you visit the website, you can find that under the webinars archive. Just an example here of our celebrity champion that's just recently joined us, just giving you an idea of our quarterly magazine. Well worth a read, always good content, great stories, latest advances in medicine, and well, a multitude of topics. Support services that we have available to you. Yeah, don't be frightened to reach out. We're there for you. There's a helpline that's staffed and manned every day during the week, and that's staffed by a clinical nurse specialist. And we also offer a WhatsApp service that accompanies that. If you want real-time fast answers, that's something that's worth using. We have a national network of support groups. The majority at the moment are virtual, although some are beginning to move into in-person. I'll come to a slide with that. If you're struggling in today's climate, which a lot of us are, and that's quite understandable, for any reason, a diagnosis and living with leukemia can impact quite heavily on your resources in your pocket and your ability to be able to sustain yourself. Please contact our advocacy team. Our welfare officer will help. Advocacy support I talked about earlier. Whatever reasons, if you're having challenges, please contact advocacy. They might be able to help to mediate on your behalf. Again, further services, peer-to-peer support is really is something that's, that can help with a lot of this information sharing. And we talked about virtual support groups and in-person support groups. These are patient groups where you can meet other people and learn from others, and who get it. You don't have to explain yourselves. So online forums, Facebook groups, and the buddy scheme. Now the buddy scheme is really important. We have a one of our buddies on our call with us today. That is a really successful scheme, and we're now offering that in on a shorter basis, and I'll come to that. We also offer counselling fund for people if you are feeling emotionally and psychologically challenged and you would like a little bit of help. Reach out to the charity, and the charity will currently is able to support with 6 counselling services. I think that, I'm not sure if there's a waiting list at the moment, but please reach out. National support groups, just to give you an idea, I think you might have seen them on revolving slides earlier. These are the next national support group meetings up until the 1st of September. These are ongoing, and there are local, either disease specific or regional meetings. There's something there for everybody. Advocacy caseworker I've talked about, and a welfare officer, but here's the details on the slides if you're reviewing slides after, which you'll be able to, so that if you want to contact anybody. We've got our first gathering on the 13th of August, so it's coming up fast. If you'd like to join us and meet people in person, it's available in a hybrid format. So if you're not confident, or if you're too immune compromised and you're not confident being masked up or anything of that nature, everyone's encouraged to wear masks. But if you don't want to attend in person, you can actually attend remotely, and it's a free conference, and it's a great opportunity where the family are all coming together, and you can meet others. And also there are these disease-specific talks as well as other interesting topics that can bring you up to speed with all advances, latest updates for your different disease. And we've got a great faculty of speakers and clinical specialists joining us from the Birmingham NHS Trust community to support with that. Fundraising, anybody ever interested in fundraising, we're certainly interested in you, because we've got a lot to sustain, and these are challenging times. So there are many things that you can do should you be of a mind to do that. Just have a look. It doesn't have to be much. Always grateful for your help. And an example of something for September, for spot leukemia, we've got Step Out for Spot Leukemia again, which is something that everybody can do because it's a walking type of activity. You don't have to run. And there's an opportunity where you can get sponsorships for yourself to do a little bit of activity during September and help others. And just finishing, we've got very active social media channels. If you want to, catch up with those, find out what's going on, always keep a look at Facebook, Instagram, or Twitter if you're somebody that uses those. I know I like a lot of it. I spend a bit of time on Twitter. I'm not too good on the others. So it's something for everybody. And just leave you with this slide. If you want to get in touch with us for any reason, our telephone is here. And alternatively, you can email us through the support email and be connected with the different service you might need to support. So on that note, I apologize to everybody. I think I've overrun by 5 minutes. Thank you to our terrific panel. Really enjoyed the conversation. You've been fantastic, and this is great information for everybody. Thank you everybody for joining us on Zoom today live, and for your questions. Thank you everybody on Facebook Live as well. Please enjoy your lovely evening. I think the sun's shining. I'm hoping it's not too hot for you still in your area. So thank you, everybody, and have a lovely evening.
Thank you.
Thank you. Thank you. Bye.
Bye-bye.
Bye-bye.